Carpal tunnel syndrome is a very common condition, sometimes related to overuse in work, but more often than not, it's simply the result of many, many years of using the hand in an ordinary manner and chronically building up tenosynovial tissue within the hand. Some of us are going to get appendicitis. We're all born with an appendix. Some of us are not going to get appendicitis. We're all born with a carpal tunnel. Some of us will develop carpal tunnel syndrome, and some of us won't. Let me explain. If we look at a skeletal model of the hand, these are the wrist bones or the carpal bones. And if we fold them back, we see that they lie in a semicircle, and across the top lies a ligament, the transverse carpal ligament. This opening is the carpal tunnel. That opening doesn't get any bigger. It's a confined space. There's just so much room there. Through that opening pass 9 tendons, a nerve, and some spongy tissue, and a little bit of extra room. If that spongy tissue swells and you run out of extra room, then the nerve becomes pinched, and that's what causes carpal tunnel syndrome. It can cause the fingers to have numbness, tingling, aching and pain in the hand, weakness or clumsiness in grip strength. Pain can radiate to the forearm, upper arm, shoulder, even to the back or into the neck. You may not necessarily have all of those symptoms. You may just have some of those symptoms. Quite often it wakes one up at night. One thinks that there's poor circulation, so they shake the hand to try to restore circulation. Driving, sleeping, several types of activities can bring these symptoms about. The definitive diagnosis of carpal tunnel syndrome is made by performing a nerve conduction test. We know the speed with which the nerve should conduct impulses across that segment covered by the nerve. If it conducts impulses more slowly, we know that the nerve is pinched at that level, and that gives us our diagnosis. It's either black or it's white. There's no in between, so we can diagnose this problem definitively. The non-operative treatment for carpal tunnel syndrome is anti-inflammatory medication to try to reduce the swelling inside the carpal tunnel. It rarely works. Sometimes if we see someone come in after a short 2 or 3 day bout of acute carpal tunnel, the anti-inflammatory medicines work. But usually when it's been going on for weeks or months, it just doesn't work. I do not advocate injection of steroids into the carpal tunnel because I believe that puts the nerve at too much risk. It's quite easy to inject into the nerve itself and cause permanent nerve damage. So really, carpal tunnel syndrome is a very simple problem. It's a mechanical problem. We have an opening this big, and this much tissue is trying to fit in. There just isn't enough room to allow everything to fit. We have to make that opening bigger, and that's done by dividing the ligament. The ligament pops up, and that enlarges the carpal tunnel and decompresses the nerve and allows more room for everything to fit. Now, since 1947, the traditional treatment has been to perform an open carpal tunnel release, whereby one makes an incision through the palm of the hand. The only problem with that is you have to cut through several normal tissue layers just to get down to the ligament. You cut through a layer of skin, a layer of fat, a layer of fibrous tissue, muscle fibers, more fibrous tissue, just to get down to the ligament. And that heals with a vertical septum of scar tissue through the palm of the hand. Every time you open and close the hand, it pulls and tugs on that scar tissue, and it hurts. When you put your hand down on a hard object, it hurts. It takes people sometimes many weeks or many months to get over an open carpal tunnel release. So not surprisingly, since 1947, doctors and patients have been a little bit wary about performing an open carpal tunnel release. And fortunately, that's led to a variety of different non-operative treatments which really don't work, but it serves to maintain chronic pressure on the nerve. The longer the nerve stays pinched, the greater the likelihood that some of the nerve cells will die. Once those nerve cells die, they're gone forever, and then it doesn't matter what operation you do, you're not going to get full return of sensation. So obviously the key here is not to treat carpal tunnel syndrome with medicine or splints or steroids simply to reduce the symptoms to a tolerable level, but rather to eliminate the pressure on the nerve so that you don't get permanent nerve damage. Nowadays, we have something much better than open carpal tunnel release, and we're not afraid to go straight to an endoscopic carpal tunnel procedure because it's safe, it's effective, and has a very, very short recovery time, about 10 days. When we do an endoscopic carpal tunnel release, we make a tiny incision here, tiny incision in the palm, and we slip in underneath the ligament in a controlled fashion. We see the ligament on the video monitor, and we divide the ligament while we're watching it without ever having cut through the palm of the hand. We put a couple of steri-strips on. We don't suture the wounds. We put the patient in a splint, use a long-acting anesthetic. This is a very short 5-minute outpatient procedure. When the patient wakes up, the hand doesn't hurt. It's a sleep feeling for a day or two, and by the time that pain medicine wears off, most people come back and tell us that they never took a pain pill, or maybe they took 1 or 2 pain pills. We see them back in the office 8 or 10 days later, remove the dressing, remove the steri-strips, and most people do not require any post-operative therapy. Now, again, there's no way to know whether or not there's been any permanent injury to the nerve. The sooner we get there, the greater the likelihood that all the symptoms will go away. If there's been some permanent nerve injury, it can take up to 6 months for the symptoms to stop improving, and we don't know what the end point will be. The end point may be no symptoms at all, or the end point may be some residual symptoms. Now, this operation, the Brown technique endoscopic carpal tunnel release, works 98% of the time. Nothing works 100% of the time. If you get a 100% guarantee, you need to get up and run. Nothing's that good. 2 people out of 100 will have a thickening of the outer covering of the nerve, and we'll have to go back a month later and do a standard open carpal tunnel procedure. At least we save 98 people out of 100 that procedure. When it's all said and done, chances of this condition ever coming back is 1 person in 20, 5%. Those are good odds unless you're that 1 person, and then it's 100% as far as you're concerned.